So, the clinical features of cytokine release syndrome include high fever, malaise, fatigue, myalgia, pain in the muscles, nausea, anorexia, tachycardia, hypertension, cardiac dysfunction, renal impairment, and hepatic impairment. Now, the most serious of the cytokine release syndrome, and unfortunately the adverse effects which resulted in both significant morbidity and most mortality, was disseminated intravascular coagulation. Therefore, it is imperative that patients, particularly starting blinatumomab, have careful monitoring of hypertension, hypobilirubinemia, and edema. Now, the interesting thing about and release syndrome is that it has an average onset of 2 days. And a lot of these side effects up here that you can see could potentially be related to infusion-related reactions. So don't forget that blinatumomab is an antibody, and therefore an antibody will have the potential for causing infusion-related reactions. So the first thing, if you suspect a patient may be suffering from cytokine release syndrome, is to rule out an infusion-related reaction. Infusion-related reactions are relatively common, so follow your own local pathway for that. The SPC for blinatumomab did specifically talk about how to manage cytokine release syndrome, and it's recommended that we interrupt blinatumomab until the cytokine release syndrome is resolved, restart at 9 microgram per day, and escalate to 28 microgram per day after 7 days if the toxicity does not reoccur. Note that if the interruption of treatment after the adverse event is no longer than 7 days, continue the same cycle for 28 days of infusion, inclusive of days before and after the interruption of that in that cycle. There is an IL-6 inhibitor which is available, tocilizumab, and can be used with or without steroids. However, blinatumomab has an extremely short half-life of about 2 hours. So in practice, we've had patients before who've started their blinatumomab infusions, and they have been riding around in bed in pain. All we've had to do is stop the infusion. Within an hour or two, the drug has metabolized away. The side effect has subsided. Then we can restart at a slower rate. So in clinical practice, IL-6 inhibitors aren't really required for BiTE technology. There have been some reports of neurological side effects, which have resulted in a specific caveat in the SPC stating that we must perform neurological examinations on patients each week of their course of blinatumomab. They SPC recommend that patients complete a handwriting test, so just write a single sentence. And this is a sentence from one of our patients, and as a record to see if there has been any cognitive impairment. However, the loss of cognitive abilities is very pronounced. Clinically, patients will be unable to complete sentences. They'll not know where they are. If they are having any of the cognitive impairment associated with blinatumomab, the mechanism of action is actually, again, T-cell directed against the cerebral tissue. Other adverse effects: transaminitis, tumor-lysis syndrome, which is probably not a bad adverse effect in terms of you're getting lysis of a disease which is quite resistant to previous treatments. So, but it's certainly something we need to monitor, particularly in the first course of blinatumomab. Infections are encountered with this monoclonal antibody. GI complications are not unheard of. Pain, as discussed, skin rashes, as discussed. The pharmaceutical aspects of blinatumomab. blinatumomab has to be given as a continuous infusion, which is unique in the way in most anti-cancer drugs. We sometimes give anti-cancer drugs as a continuous infusion over a 48-hour period, maybe, but not as a continuous infusion, 24 hours a day, 7 days a week for full courses of treatment. And it's because the search and destroy aspects of the natural killer T cells need to mean that they need to have the continued presence of the drug in the plasma. Now, that wouldn't be a problem with a normal monoclonal antibody, because monoclonal antibodies have a relatively long half-life. However, this heavily modified monoclonal antibody has an incredibly short half-life of about 2 hours, meaning that we have to give continual infusion because within 5 half-lives there will be no, i.e. 10 hours, there will be no drug left in the patient's plasma. Therefore, the search and destroy driver, which is driving the T cells to have this immune response against malignant cells, will have dissipated and gone, and that action will have stopped. Meaning that we have to give it as a continuous infusion. So patients will go home with bags of blinatumomab and will be confirmed each week for each cycle of their treatment. The in-fridge stability is 10 hours, but the out-of-fridge stability goes down to 96 hours, which means that although we assess a patient every 7 days to see if they are clinically fit to receive their next week's course of blinatumomab, it means that patients must come in the middle of that week for a bag change day. Now, this does lead to problems in day units where some staff may not be aware of whether a patient is due to have an assessment with their doctor, or whether they're due to simply have a bag change because of the limited stability of the blinatumomab. The way to get around this is to, first of all, not look into the booking system. The way to look around, the way to see if a patient is due to have a clinical assessment and or to have a bag change is actually look at the electronic chemo, the eChemo system. And if the patient is due, if the patient is booked, their date when their first week of their treatment is booked on a specific date, say a Thursday. Don't trust the booking system, because the patients will more often than not just be booked in for a bag change, and this isn't correct, because each week a patient must have a full blood count. They must have their biochemistry and hematology assessed, and they also must have a neurological examination for confirmation each week. However, because of the limited stability, patients will have to come in for a bag change. This does cause a lot of confusion in day units. So if you're asked, don't look at the booking system, go straight to the electronic chemo system, and that should tell you where the patient is. Which just summarizes what I'm about to say. And the last thing I wanted to I'll ask a question I posed myself was why is blinatumomab called blinatumomab? I managed to find this out from a very lovely paper sort of talking about the origins of blinatumomab. Apparently it originates from B lineage specific anti-tumor or tumor mouse monoclonal antibody, and is produced in the ovaries of Chinese hamsters using recombinant DNA technology. Now, it did lead me on to another question, unfortunately, which was, what does a Chinese hamster look like? Now, according to Google, that's a Chinese hamster. I wouldn't be able to comment. My references for this lecture are here. And if anyone would like me to go through any of the papers, please give me a shout. I'm happy to do so. This is still a hot topic, so things will be changing in the next couple of months. So I suspect that even the place from where we use blinatumomab might be changing at some point. Any questions, please don't hesitate to ask me. And if you have any questions, you can find me on Blood Fanning and Outpatients, where I normally look like this. Okay, thank you very much.